But let's talk about an Indiana pouch urinary diversion. So this is a urinary diversion that uses the right colon. I'm just going to bring this up and show it to you again. It basically uses this portion of the colon, okay, as the diversion. The appendix is removed, and then a short segment of the small bowel is also used. And what's really harnessed is that there's a natural valve called an ileocecal valve that basically prevents stool from going back into the small bowel. It's a natural valve, but we harness this in order to prevent leakage from this Indiana pouch. So we're going to use this portion of the bowel to create a pouch that looks like this. And so just to walk you through, this is the colon part, and this is the small bowel part. And over here is this valve that basically, when urine fills the pouch, the urine doesn't automatically leak out of this little stoma that's created. Now, what I'm showing here is the stoma is created, sometimes unfortunately, I treat very young women, sometimes not even with bladder cancer, but with gynecological malignancies that need their bladders removed. And they're obviously very body image is very important at a young age, and they don't want to have a stoma, but they can't have a neobladder because some of the pelvic structures are removed. And so we hide this little nipple in the belly button. And what patients do is they actually self-catheterize. They put a catheter into this, what's called a catheterizable channel, and they pop through that ileocecal valve, and that's how they drain this diversion. Now, when this diversion works, it works incredibly well, but because this is colon, patients are more susceptible to infections. And just to show you this real quick, generally, if we don't put it into the belly button here, we basically swing this catheterizable channel into the right lower quadrant, so it sits right here. But the biggest challenge here is that this diversion sometimes is associated with more infections, and it can be very frustrating, sort of post-operative, and really sometimes a lifelong issue for patients where they get infections in this colon pouch. I mean, most people don't, but some people do. And again, I tell patients that this diversion is really associated with a lot of maintenance. You really got to make sure that you're cathing yourself regularly, that you're sometimes irrigating the mucus in this pouch. And again, just to reiterate, some surgeons prefer the neobladder in women patients over this. Some surgeons prefer this. Again, it's a discussion with your surgeon, what they're most comfortable with, what their experience is. But it is definitely an option for the right patient.
The first question sort of goes back to the very beginning of your talk. You were talking a little bit about neoadjuvant chemotherapy, and somebody was wondering, does that actually help you to kind of get the cancer to retreat or stay more condensed, so it's easier when you remove the bladder to reduce the risk that there's still cancer someplace else? Does that have any benefit from neoadjuvant chemotherapy?
Right, great question. So here's the debate about neoadjuvant chemotherapy. The concept is exactly what you just said, Stephanie, is that there are some very bulky tumors that are very difficult to resect with a negative margin, and the chemotherapy helps shrink those and helps the surgery do a better job. There are also patients whose disease has spread to the lymph nodes or somewhere else in the body that we just can't tell with CAT scans or with MRIs or even with PET scans, but we know that there's a high risk that the disease has gone somewhere outside their bladder. And we know it's important to stop it in its tracks, and it's sometimes very difficult to give chemotherapy to patients after such a big surgery. So neoadjuvant chemotherapy before surgery serves this purpose. It basically increases the chances that the surgery cures and also makes sure that it eliminates maybe some of this microscopic disease that has already spread outside the bladder. Now, the big debate that, and it still exists, is that, some patients don't respond to chemotherapy. And so there is a risk that you are that patient and that you're receiving chemotherapy, but really delaying the treatment that's going to help you most, which is surgery. So at our center, we've tackled this, and really a lot of centers are now adapting this approach, is that what's called dose-dense chemotherapy. We basically give chemotherapy in a very short period. We, from the first start of chemotherapy, we give this chemotherapy called dose-dense MVAC, and my colleague, Dr. Elizabeth Plimak, who's very active in BCAN, was really one of the pioneers in the space. And it's basically a way to give chemotherapy very quickly. And so from when I see a patient with bladder cancer and I tell them that they're going to get chemotherapy, they get chemotherapy from the first day that they start chemotherapy to the time of surgery is really 10 weeks. So the general guideline is to get surgery within 3 months of diagnosis, and we're way ahead of that. And honestly, at big sort of busy centers, sometimes it's very hard to get on the operating schedule before that date anyway. So we're able to give chemotherapy, not delay surgery too much, and get the surgery as well. In experienced centers, chemotherapy is very well tolerated. It's not without risk, but it's generally well tolerated. Now, this debate between neoadjuvant chemotherapy versus surgery directly was really addressed by this Southwestern Oncology group prospective randomized trial, where basically patients were given this scenario and said, we just don't know what's better, getting chemotherapy first or going directly to surgery. And patients signed up for this randomized clinical trial where half the people walked through a door where they got chemotherapy followed by surgery, and half the people went through the door where they just got surgery directly. And what we know from that trial is that there was a survival benefit. People live longer if they got chemotherapy. Now, some argue that the survival benefit sort of wasn't big enough to use this for everybody. And some surgeons say, well, I'm going to give it to only the folks with bulky disease, and if they have a small tumor, I don't think that data applies. And again, it's a discussion with your surgeon. I personally think that it's very difficult for us to predict how deep and how bulky the disease is. The scans are just not that good. And because we can give chemotherapy very quickly at Fox Chase, I generally, if it's safe, if people's kidney function allows, I really encourage them to get chemotherapy first.
So I think you kind of addressed this, but this was a question, and maybe you can just do a very short recap. Is there a way to sleep through the night with an Indiana pouch or a neobladder that you can suggest?
Yeah, initially it's important to sort of really get to know your diversions. So whom I worry about most is patients who never leak. Okay, so an Indiana pouch or a neobladder, they just never leak, and they say, Doc, I've never leaked. It's great. I'm really continent, and that's perfect. But I really sort of tell those patients of mine that you got to be very careful. It's easy to overstretch. It's easy to even potentially microperforate that diversion if you never leak. What most patients have is actually a safer scenarios where they get too full and they fall asleep, and their deep sleep, they just leak, and they just learn to say, okay, if I am too full, I do need to wake up at 4 to 5 hours and just catheterize myself if I have an Indiana pouch, or just go in void if I have a neobladder. And that's obviously a safer scenario. Now, what I tell you, and I always tell my residents and my Society of Urologic Oncology fellows who train with me, I tell them, if you look at people in the first 6 months after an ileal conduit versus a neobladder, the ileal conduits, they sleep much better. The neobladder patients sometimes are exhausted. They're just not sleeping. They're being woken up by the leakage, or they're being woken up by the worry, and it's almost like having a child, while you're sort of in the infant months where you're trying to figure out and kind of learn the system, and people do get a little bit exhausted in the beginning. And I when people are trying to decide, I always tell them that it's a harder diversion to get accustomed to. And then the other, is sort of the other issue is that people get woken up again, by just leaking, because they just their diversions get too full and they leak. And there's sort of behavioral modifications. You try to drink less before going to bed, or you try to just set the alarm and just wake up. But yeah, I mean that's a challenge with a continent diversion, that sometimes you just don't know how it's going to behave, and you just have to adapt to whatever sort of capacity it has in the continents that it has.
Here's just a generalized question. Do you often take out a bladder if there's a TA but high-grade tumor with recurrence after 2 BCG inductions? Is that a recommendation that most doctors would make?
That's certainly a patient who is a that patient meets, it's all these decision making is very nuanced. So, obviously it's very difficult to give sort of advice in a particular case, but in general, patients in that group meet criteria for BCG refractory disease, and they're candidates for cystectomy. Now, there are a lot of trials, including here at Fox Chase, that are now open to patients in that situation, where we're trying other things. We have an immunotherapy trial open where we're trying immunotherapy in patients in this situation, where there are opportunities now that I think is worth exploring before you move forward with cystectomy. Now, obviously, you have to use judgment and you have to sort of trust your provider. Sometimes patients, these trials are trials. We don't know what the outcomes are. It's always, it depends on how much disease is. I certainly have told patients, yes, you're a candidate for trial, but I just worry too much that, just have too much bulky disease in there. It's recovering rapidly. I think we should sort of not risk it and get this bladder out. But there's certainly now in 2017, there are a lot more opportunities here to try to save this bladder than there were in the past.
I know you talked about the process when you're making that decision while you're actually doing the diversion, that sometimes, because of the circumstances you find, you have to come up with a plan B and go with the second choice for the diversion. But this is an interesting question. Can you change from a neobladder to an ileal conduit if there was an issue or an emergency? Is it possible to go back?
That's a great question. Let me sort of show that here. So the way that Dr. Studer, who's really a giant in this field, when he designed this particular neobladder, the way he designed this neobladder is that it's sort of, there is a built-in mechanism that, for instance, most surgeons that do this enough, you have patients who have recurred. I've had patients who've recurred in their urethra, or at the connection here, and you have to remove the neobladder. Now, as you can see, this portion of the neobladder right here is exactly the same as an ileal conduit. So you can basically bring this out as a stoma, and it's a relatively simple conversion from an ileal conduit to from a Studer neobladder to an ileal conduit. Now, not all surgeons use a Studer neobladder, and so sometimes it's a little bit more of a hassle. But this is a rare scenario. But if there's a Studer neobladder done, it's quite simple. It's not simple. It's still a big operation, but it's straightforward to convert it to an ileal conduit, because you basically remove this portion and then you take this out as a stoma. Now, removing this portion can be challenging, actually, because it's all kind of scarred in there. But there is a built-in sort of strategy to how to convert this from a neobladder to an ileal conduit, and you don't have to reconnect the ureters. Again, there's connections that we all worry about. They don't have to be remade in this situation.
I think it did, and I think that was a good explanation, and having that visual really does make a lot more sense for that. And then I have one more question, and maybe a little bit specific. So perhaps rather than answering the question because it's very direct to one patient, maybe you could just provide a couple of questions that they should ask their individual doctor. There is a patient with graft kidney. Their native kidneys are gone. The kidney installed over the left quadrant, pancreas graft in the lower right, a very short piece of the ureter. So what would they have done there in terms of having their bladder removed. Also, the patient had Crohn's symptoms in the area of the IC junction. So I'm not sure if you can answer that question because it sounds very specific, but can you give thoughts?
Sounds like a very, very challenging case, and obviously there needs to be a really multidisciplinary approach here where transplant surgeons really communicate to the urologist, the operative. I would just make sure that you get your operative notes so the urologist knows exactly sort of the nuances of the anatomy there. The one thing that I didn't mention, it's very important to consider, is overall renal function in patients with transplant versus in patients with without a transplant. The neobladder and the Indiana pouch, they're not like your native bladder. What happens is in your native bladder, when urine is stored in the bladder, nothing gets resorbed back into the bloodstream. The bladder is actually designed to have no electrolytes and no toxins come back into the bloodstream. Now, the bowel kind of is designed for the opposite. The bowel is actually designed to absorb things. So it's some of the toxins that the kidneys secrete and some of the electrolytes get resorbed back into the body. And now, if the kidneys are not functioning well, patients can go into kidney failure. And so it's important that to consider one's overall kidney function when choosing a urinary diversion. And some patients with kidney function that's not adequate are just not candidates for a continent urinary diversion. But yeah, as far as that particular patient's case, that's a very challenging case that, again, it's almost every patient in that situation is going to be managed a little bit differently. The Crohn's is obviously a challenge because you need to figure out which segment of bowel to use as a diversion. That's a challenging case where, the transplant surgeons, the gastroenterologists who are managing the Crohn's, the urologic surgeon who's going to do this really need to communicate, really need to understand the details, and then come up with the best decision. None of the options are going to be risk-free. Everything is there's going to be trade-offs, but that's a case that's really needs individualized decision making there.
Okay, that was a challenging question, so thank you so much for giving an answer. And again, it really does involve all of the different aspects of somebody's health, as you saw in this really interesting visual discussion with all of these great tools that Dr. Kutikov had. This really is a complicated procedure, and there are so many other factors that the individual doctor who's performing the procedures need to consider, as in, any comorbidities or other illnesses that you have, and, your wishes as well, and what they find once they go in. One of the things you mentioned earlier was talking about dyspareunia, some pain when females have sexual intercourse sometimes because of the changes in their vagina with their bladder removal. So I just wanted to let everybody know that we do have a number of resources. We have a number of previously recorded webinars, recent ones that were done specific to sexuality after bladder cancer. So I'd like to go ahead and thank everybody for joining us for this program. We had a wonderful audience, so thank you all very much. Dr. Kutikov, I really do appreciate everything that you've done. And again, I'd like to thank our sponsors, Genentech, EMD Serrano, and Merck for supporting the bladder cancer patient webinar series.
Stephanie, thank you for inviting me. It's a real privilege. Thank you.